Good morning, everybody. Welcome. Nice to see faces in the audience. Welcome to Grand Rounds. I guess next week is Easter, Good Friday, before I forget. So please remember to sleep in next Friday. Before we begin, I would like to respectfully acknowledge that we are located on Treaty 6 territory, a traditional gathering place for diverse Indigenous peoples, including the Cree, Blackfoot, Métis, Nakota Sioux, Iroquois, Dene, Ojibwe, Saulteaux, Anishinaabe, and many others whose histories, languages, and cultures continue to enrich our vibrant community. It's my absolute pleasure to introduce Dr. Mel Lewis, who's joining us from the Department of Pediatrics. She's, of course, our Chief Wellbeing Officer in the faculty. Mel is deeply entangled in the Canadian academic wellbeing space, serving many roles, including co-chair of the AFMC Wellbeing Committee, executive member of the AFMC Okanagan Charter Group, and executive member of the AFMC Culture of Academic Medicine CAMI initiative. She's also the chair of the newly formed Royal College Steering Committee for the National Collaboration for Health Force Wellbeing, supported with a $3.5 million grant from Health Canada. And Mel has spent over a decade in the Office of Advocacy and Wellbeing, supporting learners in undergraduate, postgraduate, and graduate studies. So I'm delighted to introduce her, and she'll be talking about the changing landscape of medical education, professionalism, and well-being. Thanks, Mel.
Awesome. It is lovely to be back in Classroom B. I have not been here since before COVID. It's like super cool. There've been some updates. It's lovely. And in the spirit of reconciliation, I was at AFMC last week in Halifax. And I met an amazing woman who is an Indigenous family doc in Manitoba. Her name is Mandy Buss. She used to be, I think she's a past president of IPAC, the Indigenous Physicians of Canada. And she taught me this thing, or she talked about this thing, and it just translated so well around how we need to sit in a circle and not on a ladder. So I bring that up because some of the things I'm going to talk about today are a little bit thorny. And I just want to remind everyone, I don't have all the answers either. I'm just going to bring these things forward. And the point is that we can sit in the circle and we can chat about them, and we can have like good relationships and be accountable for ourselves and those pieces. And I'm like specifically being a bit pokey in this talk to get some reactions and some discussion going. So thank you for being here. So I am going to discuss the tensions and tangles in medical education right now, talk a little bit about professional well-being, the weaponization of professionalism, and how this impacts well-being for all of us. Yeah. Let's try this.
A challenge to start. You just might have to click on the mouse on your screen.
Oh, fun. So I am a geeky medical educator, so objectives. So my first objective is to talk about why we cannot keep buying into this legacy culture and why we need to change. So I know I've showed you our horrible stats in our profession around well-being. I'm just going to review them quickly again to remind ourselves why we need to change and we cannot stick to the ways of the past. And then I'm going to talk about some tensions between preceptors and learners. It's not happening everywhere, but I'm certainly seeing it across the Canadian landscape, that you feel some animosities between the new generation and the old generation, new ways and old ways. So we're going to unpack that a little bit. We're going to reflect on how professionalism can be weaponized and reflects the views usually at the top of the hierarchy. And I'm going to identify some aspects that we do have control of, and we can have meaningful change and some hopeful stuff at the end. So I talked about this before, this whole, like, did we just pick people to come into medicine because they have some OCD traits and perfectionism? That's why they got 4.0s in their GPAs and scored really well in the MCAT. Like, did we select for characteristics that led to some of our poor health outcomes? So I've thought a lot about this because we know it's absolutely not true. We know that our students, when they cross our doors on day one, are as healthy, if not healthier, than their age-matched peers across all of their faculties. So we know they come in, they're well. And then something happens, and it happens right away, like even in the first 2 years. So in the first 2 years of medical school, you know, there's not a lot of moral distress. There's not a lot of forward-facing clinical aspects. You're not grappling with not enough resources to do the things you want to do. So why, even in the first 2 years of medical school, what is it about our training? There's a little bit of evidence now around maybe, you came into medical school and you thought, I finally made it, like my volunteering's done and I got the marks and I can have a sigh of relief. And then you found out about the resident match. And that like increases competitiveness. And you found out that the person beside you who wants ophthalmology has actually been doing research since grade 9, and you feel a little bit behind. So there's that piece. And then there's also some evidence that shows that perfectionism increases even in those first 2 years. And there's a loss of tolerance for ambiguity. It's really fascinating. We need to figure out what exactly is going on, because I think there's different forces at different times in our training. And we need to figure that out for sure. So we know as we go on, so medical school, we get a little bit unwell. And then when we go to residency, it peaks in terms of our unwellness. About the second year of residency, we know the most peril happens right at the beginning in those first few months of residency, which speaks to like gradual onboarding, mentorship early, all of these pieces that would support our residents. All of us, many of us were handed the code pager on July 1st. We recognize now that's probably the most well-being thing that we can do. So for residents, this is an old study actually. And in this study, it showed that 20 to 40% of residents screen positive for depression. It's now 50. So it's gotten worse since this study. So this is the American Medical Association back in 2022 looked at what are the things that are really big stressors for our residents. And as I said, these things peak around year 2 with half of our residents being burnt out. So the biggest stressors, lack of adequate physicians and support staff. That's for all of us. We just don't have enough people and we don't have enough resources to do the job that we want to do. There's too many admin tasks. I think that resonates for everybody. No control of your schedule, which is specific, I think, to the residents. The EHR systems are ineffective and inefficient, and just educational stress, those little pesky exams that we pay so much money to do. So it's interesting, and this is a little plug for the CMA too. So back when we did this first CMA study looking at the health of physicians and residents, back in 2018, it showed that about 40% of our residents were burnt out and a third of physicians, half were depressed and about a third of physicians. And then when we repeated the study in the heart of COVID in 2021, we found out there was a near doubling of burnout for both groups. And now the physicians, 50% of them screen positive for depression. And right now it's been in your inboxes, the new CMA survey. Please fill it out. It's really helpful to know like what our statistics are compared to other provinces, and maybe if there's some influences that we face that might be unique, that might speak to that, which will be super helpful. So this is my Stark slide. And this is my like poster for why we need to change and we cannot cling to this legacy culture that we love so much. So in the US, just over a physician a day dies by suicide. And suicide is the only cause of morbidity that's higher in physicians than non-physicians, which is very interesting because we're very good at having decreased rates of coronary artery disease, hypertension, type 2 diabetes, because we're smart people and we know how to get around it. And I think this slide speaks to the things that are beyond our control. We're not going to resilient ourselves out of this. The problem is not that we're resilient deficient, it's the systems that are causing us to be so unwell. So this is my updated slide again from the American Medical Association. It's interesting that in the United States, the health of faculty is actually improved a little bit. And I know why that is, but I would say in Canada, we've done a much better job with our learners, and then we've had a lot of neglect for our faculty. So the most stressful professions back in 2022, emergency medicine and hospital medicine, I'm going to call that internal medicine. So it's folks who are at the front door of medicine who don't have a lot of control over what's coming through, over workflow. You can't anticipate when there's going to be a next surge in whatever virus is coming our way, and all of those pieces. So like emergency medicine, internal medicine, family medicine, and even pediatrics showed up, because pediatrics doesn't usually show up in the top 5. But again, I think it was like the post-surge of all the viral illnesses that came after COVID really changed things, and obstetrics and gynecology. So it's interesting, and they looked at 6 key performance measures: job satisfaction, job stress, burnout, intent to leave, which is my favorite metric, feeling valued, wouldn't that be nice? Total hours per week spent on work-related tasks. So they looked at all these things and then determined who was struggling the most. So again, just a reminder, Burnout is not a diagnosis and it has nothing to do with us. If we're burnt out, it's not a personal failure. It's because we are getting crushed by the occupational hazards around us. And when the Maslow burnout scale was contrived by Christina Maslow, it was always intended to measure occupational hazards, not the people. And it's been really misused. So if people say, oh yeah, that person's just burnt out, if they were only resilient enough. And then I've heard all of that rhetoric too, you know, maybe we should select medical students for resilience. Maybe we should do that, not realizing it's actually the system that's crushing us. I love this slide. This comes from the work of Shanna Feltz and Lottie Derby and others, and Christine Simsky, who I love, reminding us that burnout is primarily a systems level problem. It's mostly overwhelming workload. It's not having enough resources to do the work, and it's stupid stuff. It's all of the administrative tasks that are detracting us from doing clinical work. It's interesting because if I talk to residents or faculty members, they're not burnt out because of tough clinical cases. It's not the patients. It's not the patient care that's burning us out. It's all the other stuff in between. It's the politics and it's the things that we have to grapple with that maybe we weren't taught an approach to in medical school. So we really need to focus on the 20%, or we focus too much on the 20%. We've talked way too much about mindfulness and yoga and fatigue management and those pieces. The big issue is systems level stuff. And just because it's systems level doesn't mean we can't influence it. We're a part of the system and there's many things that we can do, but we just need to keep our eye on what the real issue is here. So the case for healthcare well-being. So I know why the United States is doing better from a faculty point of view, because if you have well faculty, your organization makes money, right? You're more efficient, you see more patients, you make less errors, there's less litigation, all these pieces. The business people in the United States know that they should lean into this. Like, I'm the only chief wellbeing officer in an academic setting in Canada. You can't swing a cat in the United States without hitting a chief wellbeing officer because they're everywhere. They're in hospitals, there's an academia, they're everywhere because it makes monetary sense. The problem in Canada and the public healthcare system is that we're not an investment, we're actually a draw on the budget. So it's been a real struggle. And I think that's why we've done a much better job with our learners, because we're compassionate, lovely people. And the organizations around us have not supported us. The moral case, I have this awesome friend, his name is Salim Razak, and he always puts things so aptly when we're together. But he talks about, like, there should be a moral reason why people should, you know, want to care for us, but we're treated more as objects versus subjects in our profession, right? Like subjects worthy of compassion, worthy of care, those things, but we're just objects to fill a call schedule, to fill a need, all of those things. And it's sad. The accreditation case, that works, but it only comes around every so many years. I mean, that's one of the biggest sticks we have in terms of supporting places that are having challenges and need some extra support and some rearrangement and renovation. There's a tragic case. We all know folks in our environments who have completed suicide or who have left the profession. We're sad for a minute and then nothing changes. Like it's super tragic and we're super sad, but things go on the way they have before. And then there's the political case. So why do I have $3.5 million from Health Canada to work on well-being? Well, it's a bad look for the politicians that 6.5 million people don't have a primary healthcare provider, and they need to get reelected. The hard part for me to watch, and I've sat nationally on a lot of places about workforce needs over like the next 5, 10, 20, 100 years, and we knew this crisis was coming. But the healthcare budget, the provincial budgets mostly, is in the healthcare sphere, and they want to get reelected. Balancing the budget is a piece of that, so it's this short-term look. And they're not looking long-term. So now we have, 5 new medical schools that are coming online? Well, it's like too little, too late now when we saw this cliff coming like 20 years ago. But I'm really leaning into the political case because it's been very helpful for me. So the cost of burnout, I tell all of our funders and our leaders and our policymakers this slide all the time. So what did it cost us personally? Broken relationships, alcohol and substance use, depression, suicide, as we've talked about, and then all these other things around decreased quality of care, increased medical errors, decreased patient satisfaction, decreased productivity, and professional effort. And then the big one that I'm focusing on is physician turnover. So I'm rebranding well-being as a retention strategy. And that's gaining hold, because I think a lot of people think that I'm the chief wellbeing officer, that I'm scheduling yoga, and that I'm the person who's on the distress hotline, not realizing that I'm trying to like really combat some of these systemic issues. But like, leadership listens to this. If they can't attract and retain their workforce, that's a problem. And when I do my metrics and studies around our places, and I do intent to leave, that is my biggest metrics that moves leadership to action. If they find out that 50% of their faculty members are thinking of leaving, and there's already been quite a few departures, that'll make people listen. If they find out that 80% of their residents could transfer if they could, that's a problem and tells us that there's a pretty toxic environment that needs some care and attention. So this has been more helpful, the whole rebranding piece. I just want to remind you some of the stressors that we faced when we were younger and face now that we are staff. So the learners, curriculomegaly is a huge problem. We keep adding stuff into the curriculum, you know, opiate crisis, EDI, Indigenous health, point of care ultrasound, like all of these things are really important and they have to go in the curriculum, but we're not taking anything out. We're not taking out anatomy. Like we're not taking out cardiology and we're not taking out these things. So like we're just packing it in as we do. And of course, our poor learners are underpowered and they're mistreated. Residency positions, this is of course the stress in medical school, because if you want to be an ophthalmologist or a plastic surgeon or an internist, it's not guaranteed and it's super stressful. And then if the Carms gods got it wrong and you end up in the wrong place or in the wrong profession, that's super stressful. And the ability to transfer is super limited in our system. Underrepresented students face very different stressors, and it's really hard to maintain identity through our system. And I feel we're doing a much better job at the admissions end of things, but I don't think we have enough supports on the other end to make sure that folks can be who they are inside and outside of medicine. CBME, I've got a slide about the dark side of CBME. Lots of administrative tasks, exams that loom over our students' heads. I, in my last year of residency, had a baby. So I wrote my exam and then I had 6 months just to learn. It was the best 6 months of residency because I could just be like, what do I need to learn? I'm going to find that and just like immerse myself in this learning piece without thinking about this darn exam and the shame that I would feel if I didn't pass it. Service to education ratios, that's a huge tension because honestly, residents are a really good deal. They're a cheap source of labor, and this is how we have staffed our hospitals for generations. And on the staff side, competing roles, all the things that we do that we never thought we'd do, like we went to medical school to be doctors, but we're administrators, we're researchers, we're academing, we're doing all of these things. And no one told us that that's an impossible task to be awesome at all of those things. And that, you know, I wish someone had told me it's okay, Mel, just to be good enough. And the other thing for me is sometimes you just have that overwhelming week and you're like, oh my gosh, how am I going to get through these things and be awesome at all of them? I've just learned, you know what, good is sometimes just fine. And sometimes done is just fine too. But I wish someone had told me that earlier in my career. This whole lack of training in leadership and conflict, and I've said again and again, like I would like to insert the leadership course in first year of undergrad, because oh my gosh, we have dealt with some thorny issues, especially over the last couple of years. I wish I had an approach to that. Like I had an approach to toxic places and toxic people. I wish I knew that because that's what drains the life out of me. Of course, lack of resources and an overwhelming workload. Technology. I just had a grad student who defended her thesis around well-being and the EMR. You will not be surprised to know that it eroded everybody's well-being and many people had many negative things to say. But at the end of the day, every single physician said they wouldn't go back. They wouldn't go back because it improved patient care. But there would have been lots of ways if we could have onboarded this in a different way. We could have had ongoing support. Many things came out of that work. We need to get that published. Institutional betrayal. I'm going to talk a lot about that in this talk because I think that's one of the drivers of the animosity between the newer generation and the older generation. Perfectionism and being human. this is going to be a thread through the rest of this talk. So for both groups, in terms of stressors, they're overburdened by the sheer number, complexity, and frustrations associated with their daily tasks. This NASA task load index is being used more in the well-being space. I love it because it goes across professions, but doesn't it resonate with physicians? When you look at the last one, frustration, how insecure, discouraged, irritated, stressed, and annoyed were you when you tried to accomplish that task? Like that just speaks to our daily work, let alone some of the more common things, you know, how mentally demanding was the task, how physically demanding, how hurried or rushed was the pace of the task, how successful were you in accomplishing what you were asked to do, and how hard did you have to work to accomplish your level of performance, which often speaks to the lack of resources we have to get things done. And this is super interesting. I mean, not only that for every 10% decrease in the physician task load, there's a 33% decreased odds of experiencing burnout, but it's interesting for women, we tend to have higher task loads, and that translates into burnout. And for men, when they are struggling with task loads, it equates more to intent to leave, which is really interesting. But I think we need to dig into this research because I think it's the sheer number of things that come at us every day that are really eroding our well-being. Here's my CBME, a cautionary tale. So I applaud the Royal College for publishing this data that 77% of residents indicated that the transition to CBD had a negative impact on their health and wellness. And this was related to faculty completions of EPAs or not completing EPAs, I suppose, the administrative burden, limited opportunities to complete EPAs, concerns around value and validity of CBD, cognitive load, and inadequate feedback. And I think there was a lot of unintended consequences to CBD that we're unpacking now. And I know the Royal College is doing like CBD 2.0, looking at a lot of this research to figure out how we can do better. Because it would have been interesting. I haven't seen the stats on how it eroded the faculty well-being, but we know it's substantive. It's not that we don't want to fill out the EPAs in our inbox. It's just that it's one of 100 things that we're supposed to be paying attention to. So in addition to all of the things that both groups are grappling with, our personal characteristics are interesting in healthcare, and perfectionism is one of them. And it is an invasive weed in our culture that we have to address. And it shows up in funny ways. Like we all have a bit of perfectionism, right? So perfectionism keeps you stuck because if you know, no one can do it better than you, you can't delegate that task. So you're just going to hold on to it. You're going to procrastinate because you're going to come up with the perfect thing. So like that takes time. So like you just, you know, keep putting it off until you find the perfect time. You're indecisive because, you know, again, you got to pick the perfect thing. Conflict avoidant because that's messy. You have imposter syndrome because you actually think everyone else is perfect and you're the only one who is not. You ruminate. You see Brenda Hemmelgarn in the hall and you have a conversation with her and you're like, I can't believe I sounded so stupid. I really don't know why I said that. Or you send that email and you're like, why did I send that email? I shouldn't have sent that email. And this negative highlight reel that goes around in our heads, we don't remember the awesome stuff. We don't remember when we nailed it. We don't remember when we got that diagnosis. We remember every negative thing. The positive stuff like bounces off us, but our personalities, we just like suck in all the negative stuff and just let it run. And of course, perfectionism leads to overworking because you're people pleasing, you're perfect. You can sit on that committee, you could be the program director, you can do it all. You're multitasking and you're a workaholic and you think you can do all these things well, and we can't. We think we can get away with it until, you know, several balls hit the ground. We don't have work-life balance. And what are these things called boundaries? What are those? So the goal is excellencism and not perfectionism. I found out these are actually real words, excellencism. And there's real evidence to show that folks who strive for excellencism actually do better on exams. They actually do better in like everyday daily tasks. And we've all done this. You know, when we've tried super hard, we had that like person that we didn't want to look like a loser in front of. So we tried so hard to be the best that we could. And it always failed. We always were not doing things that we normally would do. And if we were just ourselves, we would have been fine. But we were trying too hard. We were trying to be perfect. So the paradox of perfectionism, brings out the worst in people. And if I see fear in a place, like fear within a division or a group, I know perfection's there somewhere. Fear generates more mistakes. Like I said, if you're trying to be perfect, it doesn't work. And it's not driving excellence if you're a perfectionist, but it's being impaired by it. I love this Gustavo Rossetti. He's got an awesome blog that I take a peek at every once in a while. And the biggest thing about perfectionism, it can't coexist with psychological safety. And if you don't have psychological safety amongst your group, oh my gosh, it's really hard to have a health promoting learning in a work environment. And perfectionism sets you up for shame, guilt, burnout, anxiety, and anger. And it sets an impossible, unrealistic standard. And I see it amongst especially physician teachers because they become very nitpicky. Their expectations are unrealistic. And we've seen people in all of our environments of like docs who are amazing. They know every New England Journal article. They go above and beyond for their patients, but they're brutal to their learners. And again, that's perfectionism. They have unrealistic expectations for them, and it can take them out at the knees and can absolutely be toxic for a learning environment. So another stressor in our learning environment that I'm going to start chipping into now, this is like kind of like the thorny piece of the talk, is this gulf that's erupting between residents and staff. And the conflict among teams that is definitely driving burnout. And we've got some evidence around that. So there's been an erosion of hierarchy, and our learners are pushing back. They're unwilling to conform to the status quo. They are going home after 26 hours when they've been on call. They've had well-being and EDI literacy. They've been told to look after themselves. They know our horrible outcomes, and they're trying to do things differently than we did. They're calling us out when we commit microaggressions, when we're giving didactic lectures on the ward, all of these pieces. These are unexpected because in our generation, we put our head down and we just did whatever we were told. And we had insults hurled at us. I think I was told I was the worst clerk ever in history, like all of these things, but we never thought we could speak out. But we've got a new culture now, and it's a bit jarring. This bidirectional feedback piece, there's lots in the literature now about who's got the power. Do the learners now have more power than the faculty in terms of this evaluation piece? And then of course, there's all these pressures that are like crushing all of us and probably not making us our best selves, the EMR, CBME, COVID, all of this. But the biggest thing, like to go back to like institutional betrayal and faculty betrayal, we were told that we would work very hard in residency. We would not get very much sleep, but we would get payback at the end. We were told it was supposed to get better. We wouldn't be sleeping in house anymore. And someday we would, when we were the residents running around doing the work, we would have these people called residents who are helping us doing the work and helping us do the documentation and all these things. Well, the tables have turned, and that is not what is happening now, because we got too many damn patients and we don't have enough people. And of course, our med schools didn't keep pace, so we do not have enough residents. And the ratios that we had when we were in training have shifted and changed. Expectations have also shifted and changed. So we're playing on the same team, but we have very different expectations for what is reasonable and healthy. And I think everybody here would agree that what we endured was neither reasonable or healthy, but we didn't think we had a choice. And I think we thought it made us better physicians, which is a point of debate. So a conversation in a hallway. I have this conversation all the time. So I now work at the Aberhart Center. So I have a chance as I walk through many hallways for people to come at me and make statements. This is one of the most common statements. Can you believe it? I had the most amazing case come in yesterday afternoon and my resident was post-call. So I asked them if they were going to stay and see the patient. And the resident politely declined and said they were going to go home. Wow, residents these days, where's the commitment? And I think we've all heard this conversation, and we really need to think about it and unpack that. So there is an amazing writer in the New England Journal. I'm sure many of you have read Lisa Rosenbaum's article. She's a third generation cardiologist in New York. She writes a lot in the New England Journal, and she's got a blog, and she's got a podcast and all these things. And her dialogue is around, we're soft on crime. We're too easy on our trainees these days. This well-being thing, we've swung too far, and they're not going to be able to do what we're doing when they become staff. And it's an interesting conversation. It's all anecdotal data, and she gives a lot of interesting examples from her own career, and she is an amazing writer. But she'll say, like, I had microaggressions committed at me, and she'll go in and specifically talk about them. It didn't hurt me. I was fine. I find it interesting she still remembers them decades later, and I wonder if they had more of an impact than she wonders. And she totally doesn't talk about our well-being outcomes in all of this, and wants to cling again to this legacy culture that we had. And my piece of all of this is that we have no evidence to say that survival, sacrifice, and suffering are required for excellence. But that's the message. And I wonder too, if we have to believe it. Like, we have to believe that the suffering was worth it. Like, all the time we spend in the hospital, what it cost our past selves, what it's costing our current and future selves. Like, we had to buy into it, that it was for a reason. And medical educators have been bombing my inbox with her stuff, because they're like, what are you doing, Mel? Like, I don't know if we can buy into your stuff. Again, even though there's absolutely no evidence. I wrote an article that we're trying to get published as kind of a rebuttal to this argument. And the piece for this around for us is that well-being and excellence aren't two different sides of the coin. We're on the same side of the coin. So I passed this guy. He's out at the Dvorkin. He's like gazing fondly, kind of in a glazed way towards the colonoscopy suite. So we've also been this person, right? At some point in our life. I don't really think that we want this person to stay and see that life-saving case. I don't really think this person, even if they did, because they might, because they think it's a test, you know, oh, would you like to stay? If they stayed, they'd actually retain or learn anything. So my whole point is, I obviously don't believe that well-being is undermining competence, and is competence undermined by burnout in terms of all the things we've talked about and all the things that we have entrenched in science. And we know objectively that it increases medical errors. It erodes professionalism and compassion. There's more disengagement. So my whole piece around this, and if Lisa was in the room with me, we'd have such a fun discussion in a circle, that well-being equals engaged, compassionate, skilled, resilient, and effective learners and faculty. So, is going home unprofessional? Who decides? It's this guy. This guy taught all of us. We know this guy. He looked maybe a little bit different, but we know him, because professionalism and what we put as those standards is upheld by the traditions of the most powerful in medicine. It's like he's looking in your soul. I can't even look at the slide. So professionalism, the problem, has a very flexible definitions. Is it a term to support respect and trust towards colleagues and patients? Most people could agree on that. Or is it an institutional term to support submission, obedience, and assimilation? And I see this in this place and nationally, you know, learners who have been called unprofessional because they spoke out at their Royal College internal or external review. That was unprofessional of you. It was unprofessional of you even just to bring concerns forward about the program. That's unprofessional. We're going to put you on a learning plan for that. That's unacceptable. So we see it around our places, and it's a bit troubling. It's interesting. I was sitting on the stage for ICRE, and we were talking about what we could agree on in terms of what is professional and what is not. And I'm sitting with these amazing people who are way smarter than I am, like Tasha Wyatt, and it was a group who was across, it was an international group, and we were talking about professionalism in general. And so we were like, well, could we say it's being patient-centered? And then we realized that that's not necessarily true either. And we all couldn't agree on what the definition should be. So another threat to well-being is being able to maintain our identities in and out of the clinical setting. Historically, we were one kind of person outside of medicine and a different kind of person inside of medicine. And this
often affects our junior colleagues and our learners. And we talk a lot about identity formation, but what if we are purging diversity in the name of professionalism, and we perhaps subconsciously still envision the doctor as that white, het, cis male dude that I showed you in the previous 2 slides. So, and I think this resonates with all of us in terms of the things that we experienced during our training. So as you can imagine, I got called out a lot for my personality. I was always too informal. Mel, you got to button it up. You have to be more formal with people, more deferential. And can you start introducing yourself as Dr. Lewis? And this whole Mel thing has got to go. The whole affect, you should smile more. Your appearance, what you wear. It's only now, after being in medicine for like 30 years, that I sometimes wear jeans to clinic. But I think I was told by someone that was absolutely unprofessional. And I actually didn't do it because I was like fearful, especially when I had learners with me. Like, Lord knows my patients don't care. I mean, they mostly vomit on me. So it's fine. Use of language. So like I deal with a lot of adolescents. So I got called out for like, I'd be working with an adolescent and I'd be saying, oh, that's really shitty that happened. And they're like, no, you can't say that. That's like totally unprofessional. Even though I know in my head that like helped develop rapport with that adolescent and those pieces. But again, it curbed what I did. And it was either, a lot of it was unconscious in terms of how I just went towards what was acceptable for the hierarchy, because it was easier. I mean, medical training is not easy. So you just do the thing that you think you need to get ahead. Social and political opinions, we're going to unpack that a little bit because that's been super thorny. I mean, advocacy is a CanMed's role, but this has caused a lot of havoc across North America. And then approaches to patient care. There's a lot of ways to approach it, but often when we went to school, there was one way and we were supposed to do it that way. My whole goal is I hope that person becomes the new model of what a doctor you imagine that they would look like. Has anybody read this study from vascular surgery? Do you know about, I love it. This is like the best find ever in the literature. So in 2020, from the Society of Vascular Surgery, the most eminent journal for vascular surgery, they published this study, we'll call it. So all of the research were men, and what they did is, it's kind of creepy. They looked at 230 some residents' social media, and they had criterion to decide what was professional and what was not. So if you were shown consuming alcohol, not being drunk or anything, but you had a glass of wine in your hand, unprofessional. If you had a bikini on, unprofessional. You could wear board shorts, by the way, but you could not be in a bikini. If there was profanity in your post, if oh my gosh, there was controversial political or religious comments made, or there was controversial social topics like abortion and gun control, unprofessional. So this was the best thing to ever happen because, oh my gosh, the backlash was swift. There were so many women in medicine who posted pictures of themselves with the bikinis. It was all over the internet. And so this whole hashtag #medbikinis, and then it led to the retraction of the article. And you have, like, all you have to do is get on your little Googler and do hashtag #medbikini and retraction, and you can totally find it. But in terms of the apology from the journal, it's a good read. And then there was, of course, a lot of letters to the editor around this. So I love this one. This was actually from a med student. And about hashtag #medbikini, that it demonstrated solidarity to demonstrate how maintaining life outside of the clinic shockingly does not detract from one's merit as a physician. In fact, it makes us more human. Amazing. So again, I'm back on stage at ICRE trying to figure out what's professional and not professional, because we're supposed to be like the experts at the front, and we are clearly not. So is it unprofessional to have personal boundaries? Is it unprofessional to go home at 5? Is it unprofessional to leave after your call shift, even though there's work to be done? Is it unprofessional to put yourself before your patients sometimes? How many times have we come to work sick? How many times have we come to work and there's a personal crisis evolving in the background? How many times? Is it okay to have a bad day? So it's hard to be any of us in leadership when we have a bad day.
maybe we didn't handle things perfectly. Maybe we were a little passionate in that committee meeting. Maybe like we weren't our best collaborative self. We're allowed to have bad days. We have to apologize for them and be accountable for that behavior. But like, we're humans. We're doing the best that we can. There's a lot of things coming at us. Is it unprofessional to have an unexpected personal or health crisis? Like the first thing that we think of, something's going on, is like, oh my gosh, I've got a call. I don't want to burden my colleagues. I got to figure out a way to do that and plan my dad's funeral. Like, this is how we are. We are the weirdest profession. And is it unprofessional? Because one of the things about, we were tagging around, like, what is the definition? Competence. Like, it's professional. Like, we need to be competent if we're professionals. Well, sometimes we make mistakes. And sometimes we all make errors. Like, I mean, let's be honest. And we're trying, but again, we're human. So even like some days we're less competent than others. And is it unprofessional to be who we are inside and outside of medicine? Like the way we usually dress outside of medicine, if we bring that in, can, like, in the old days, hopefully it's changed, but like I remember in med school, anybody who had like some cool ink or had piercings, it all got evaporated right before the residency match because we were trying to look like what the PDs wanted us to look like, right? It was what this guy, you know, like the hierarchy, what that expectation was. He's also looking into my soul. And then, of course, a lot of unprofessional behaviors are often symptoms of something else that's going on. And I have to say, before I worked in the Office of Advocacy and Wellbeing, I was just as guilty as making a lot of assumptions. You know, I would have, this is a true story. I had a learner come in and came in late to my clinic with the cup of Starbucks coffee in their hand. And, you know, we've all rolled our eyes at that. And then, you know, I found out the backstory. You know, his dad was dying in hospice and like he was, you know, reluctant to leave and he hadn't slept all night. And that was why he was there. And especially working in the Office of Advocacy and Wellbeing, I found out the backstory. Like I found out some of our learners who had such overwhelming anxiety, it took them half an hour just to get through the door at the U of A, and then they were okay. But like I didn't understand the backstory. And in our profession, we're pretty judgy. And so like if we could have like that benefit of the doubt kind of mentality and give people like a break. So I'm having a bad day and I'm maybe a little bit not on my game. If people said, Mel, are you okay? Like, what's going on? I mean, there's a difference between like one-offs or like not happening very often versus like a pervasive way of being. And this whole think ill before evil, I was heavily influenced by this guy named David McKnight, who was an anesthetist at U of T, and he was kind of one of the fathers of professionalism in Canada. So I always have that in my head when I get a bit annoyed with things to think, okay, think ill before evil. This is the thorny piece that we've really struggled with over the last year. So I'm a huge fan of Rachel Alloway and Tasha Wyatt. When George Floyd came about and it was the Me Too movement and climate change, they started wondering whether or not we should be teaching professional resistance in our curriculum. This is a really touchy subject. And this was far before, you know, the war broke out in the Middle East again. And so, and all of the issues of how we were going to manage folks having very strong opinions about these things in social media and how it should be managed. Every dean wishes now that this had been in the curriculum when they went to medical school because it's been so hard. And we've seen, you know, relationships dissolve between faculty members, learners, all of these things, such horrible unintended consequences when, you know, this work is hard. And if you don't feel like you're in a supportive learning and work environment, it's really, really challenging. So I got to hang out with Rachel last week. And she has these guardrails and principles around professional resistance that I think would have been really helpful, like if we had learned them a few years ago. But she has some principles. So like if you are going to advocate for something, because our learners are confused, like we tell them they need to be advocates and we tell them they need to be leaders. They're CanMed roles, for goodness sake. And then they do it and they get sanctioned or they get suspended and all of these things. And it's been a really hard road. So the principles were it needs to be affirmative. You need to be for something. It needs to be deliberate and very intentional. It needs to be proportionate to serve the need. It needs to be constructive. You're building something, and you need to be accountable. And Tasha Wyatt said something to me at ICRE last year. She said, you know, I feel like the guardrails around all of these things are, you know, you can't go scorched earth and you can't affect the relationships
around you, with your patients, with your colleagues, and those pieces, and understand, how important that is. And like I face this a lot in my clinic too. I look after a lot of queer youth, and there's been a lot of learners who've been very frustrated with me when I haven't signed on to petitions and those things against Danielle Smith's stance, especially for our trans youth. And I said to them, I can't risk it. Like I can't risk it. I need to keep my spaces safe for everybody. And if I have a really conservative family in my practice and they see my signature there, I worry they won't feel comfortable coming to my clinic, and maybe their kids need me the most. But I think too, with learners, they haven't had that relationship with the patients, right? They haven't had that accountability to the patients. They're kind of like, 2 rows deep. And so it's different. And we maybe see it in a different way than our learners do that don't like have that ownership piece and that responsibility. But I actually do believe this is something we need to talk about in our curriculum. We need to be able to have these hard conversations without them destroying relationships. And it's been something that's been really missing. And I mean, everybody's grappling with this at all levels. I know Zoya Zain came and spoke at Grand Rounds about this study, but just to say that workplace discrimination and harassment amongst our residents is alive and well. When she looked at about 100 residents at U of C and U of A, the cisgender female and gender diverse participants reported more frequent harassment, mistreatment, or discrimination compared to their cisgender male counterparts. And over 40% of BIPOC residents had been the target of a racial slur or a joke from an attending or colleague in the past year. And 45% of participants had witnessed an attending or colleague using a racial slur in the past year. It's interesting, we actually have no evidence that discrimination, harassment, and racism is actually improving. This is a quote from a paper I'll talk about. So the surgeon would be asking opinions on what to do with people. And I, a female clinician, would say, this guy should be managed medically. You should not take him to surgery. And they'd be like, oh yeah. Then one of the male cardiologists would say, yeah, you should take him to surgery. As soon as the guy said it, that's what we're going to do. But if I said it, not so much. So again, speaking of discrimination, given that we have been male-female equal for decades now in medicine, 50% of female physicians still face discrimination and harassment. And it's increased in cardiology for whatever reason, which is why Shannon did this study. So Shannon Rizicki is amazing. She also did the other discrimination study. She's actually a U of A grad. I had the pleasure of teaching her many years ago, and she is amazing. So I just try and sit beside her and love doing research with her. So this was a study done at Cummings down the road in cardiology, and it looked at women in cardiology and anesthesia, cardiologists, cardiac surgery, and the learners in the area too. And it was a groundbreaking thing, and good for Shannon because her dean is a cardiologist. And to get these things published took a lot of courage, but she did 15 semi-structured interviews. And all participants provided examples of workplace gender-based discrimination ranging from microaggressions to sexual assault. And then the sad thing was that the participants talked about choosing different specialties and practice locations as a result of their harassment and discrimination. Even when they went through formal processes, it often didn't work out in their favor overall. And that the participants demonstrated a range of coping strategies from denial to adopting a different personality, being a little bit more forceful, being a little bit more masculine, all of those pieces. So this was just in like 2022, I think this study came out. So again, just speaking to psychological safety in general, like this is something that we have to have as a foundation for all of our places if we're all going to thrive. The ability for us to show up at work and be who we are and to feel like we can take a risk in front of our team without being belittled and put down and those pieces. So this is something we need to really keep stock of. So, and I've gone through this before just to talk about, we want to have high standards and we need to have high psychological safety, and that's where you end up in this learning and high performance zone. But unfortunately in medicine, we have high standards, lives are on the line, and we often, most places have low psychological safety. So you just sit in that anxiety zone. You just wait to be taken down at the knees or someone to think less of you because you made a mistake. And you're certainly not going to put your hand up and say, I'm struggling, because then people might think you're weak. So
in my place of being the chief wellbeing officer for like the last 4 years, these are the things that I know are the 6 critical components to health promoting learning and work environments and burnout. So health promoting policy, having awesome policy that supports us. And this can be around accommodations, leaves, schedules, promotions, like fairness, right? So that everybody gets, their shot at the vacation times and the long weekends and all of those pieces. Resources, both professional, we need the resources to do the jobs we want to do for our patients. We also need personal resources to keep ourselves well. Workload, when we romance about, we work so hard, I would say like our residents, like the complexity on the wards right now is so different than when I was a resident. Like I had kids in croup tents. Croup tents did nothing, by the way. We put kids in croup tents for decades. I had kids who were failure to thrive. I had kids who were social admissions, which were really tough cases, but I knew they were going to be alive at, 8:05 in the morning when I was on call. And now we've got trach vents on the wards and high flow and all of these things. And so the complexity, like you can't be in hospital unless you're really, really sick now. And that wasn't the case when I was a resident. Administrative burden, this is a huge piece, and that's why I'm so grateful people like Jake Hayward are doing like the AI and machine learning studies to see if we can be more forward-facing with our patients while somebody else cobbles the notes together in a much better way. Leadership development and support, we know if you've got a good leader, if I've got a place that's thriving, there's a good leader there who understands psychological safety and understands, participatory management styles and those pieces. So if you really support our leaders because they've got a really hard job, your engagement and your burnout just plummets. And again, I've talked lots about psychological safety. This is a piece I brought up before in the past, but don't forget it. Physicians who spend 20% of their professional effort focused on the dimension of work they find most meaningful are dramatically lower at risk for burnout, like 50%. So think about what you love to do, whether it's medical educating or academia or clinical care, or what is that thing that fills you up. Make sure you're doing it. Make sure your leaders know that you need to be doing that thing. And if you are a leader, make sure the people around you are doing the thing that they like to do. I just want to go into this change curve. So let's look where we're at as we navigate the changes in medical education and our culture and our attitudes around what are reasonable occupational hazards. So I like this change curve. I've adapted it for our current circumstance. I want to get it right. So first of all, there's the shock. There's the shock that the new generation is not abrogating themselves to medicine. They are going home. They are choosing themselves. They are choosing their family. This is shocking to us. And they're also calling us out and giving us constructive feedback. So this is a shocking turn of events. And then there's denial. I think I'm an amazing pediatrician because I worked 80 to 120 hours. That's why I'm so excellent. We need to keep doing that. I mean, my family, my kids, my friends, they didn't miss me. I was good at work. And when I went home after the 120-hour work week, I was great. I was like so compassionate and so lovely to be around. I wasn't irritable at all. And those microaggressions that we faced, when I was told I was the stupidest clerk ever, I mean, they didn't affect me. They made me stronger. So that's great. And in this denial piece, it's like, okay, where is that Lisa Rosenbaum article? Because I'm just going to put it under my pillow because it's going to remind me why this well-being thing has gone too far. And we are going to cling to the past, cling to the way we've done things. I'll just ignore the fact that we're, losing our colleagues because of our culture. And then there's the frustration. Oh my God, there are too many patients and there are not enough people. And then there's depression when we're sleeping in house on the surge wards. And these people that we were promised called residents sometimes aren't on our teams. And these people called residents who know how to do the EMR so much better than we do, even though we're smart individuals. And they've done things that we actually don't know how to do, and we've relied on them. So where are those people that we were told they'd be there? And then for the experimental stage of things, we see it. We're experimenting. No, I can't do that search and select committee that meets at either 6 a.m. or 6 p.m. on consecutive Tuesdays for the next 6 weeks. No, I can't do more service. I'm done. I can't do it. And we see we've got in internal medicine, you've got backup call schedules, like you could actually be sick. So we're experimenting a little bit. And then in terms of decision, learning to work in a new situation, I'm going to be who I am inside and outside of medicine. I'm wearing my jeans to my clinic.
And I can integrate both my personal and my professional identity. And life's too damn short, and we need to say no to stupid stuff. And we're all doing lots of stupid stuff that has nothing to do with patient care. So integration is when we finally admit our limits, admit we're human, that we're showing our vulnerability, we're abandoning perfectionism, and we're saying yes to ourselves and to our families, and we don't feel guilty about it. So that's when we finally integrated it. So my final slide that I love, instead of praising people for being resilient, change the darn systems that are making them vulnerable. This is the piece. We're all very, very resilient people. We really need to like lean into what are the occupational hazards and what are the cultural pieces that have been crushing us for generations. And then we'll be a much happier, much more professionally fulfilled people. So that's all I have to say. I was hoping to leave more time for questions, but
Amazing, just fantastic presentation. We really needed that. So thank you. I have a million questions, but I'm going to hold off because I get direct access to Mel and we'll have a couple of minutes for some questions.
If this is 2 hours, can we just get Mel back?
Yeah, it's not a bad idea, actually.
Yeah.
It's, there's a question up there.
Thank you. It was really interesting. One question for you. I think there's a lot of value in changing conclusion. How would you suggest, or what would your recommendations be in terms of changing things with regards to our patients? Since post-COVID, I think there's tends to be more expectations from patients and more anger towards physicians, which I think you're right. Like, I think most of us love the clinical aspect of things, and it's not the clinical part of it that drives burnout. But I think from what I understand from CNPA, it sounds like number of complaints to the college have gone up by like 300% post-COVID.
and it's hard.
Maybe just repeat for.
And we were just talking about like how do we face like the challenges that we're faced with patients who are being a little bit more demanding and maybe a little bit more litigious or more complaints in those pieces. That's been really hard. I think you can break it down into lots of things. I mean, over time, our patients have become more consumers than patients. There's been an erosion of trust in terms of what we have to say. In my practice, I don't know what the naturopaths are doing, but my patients believe them far more than they believe me. I'm still, they're doing something there that I have to figure out. But I think part of it is number one, being vulnerable and like for people to recognize that we're humans and we're trying the best that we can. In medicine, we've often put on this facade that we're all doing okay and we're not struggling, which was a real problem in COVID. And then in Alberta, in particular, we've had this government who has like torn down healthcare workers and hasn't shown a lot of respect. And then I think the public have followed suit around that. So it's messaging. In terms of like for our patients and just being people with them so that they see that like we are trying. And then, I mean, we have to get to the government and to see the harm that they're causing us in terms of the messaging out to the public around that. You would think that physicians are working against patients and some of the rhetoric that we've heard in media, which hasn't been helpful. And we got to stick together. Like when things are bad and you've got a really challenging patient or you've got a patient complaint, we have to talk about it. And we haven't done that historically because we all face it. And we have to stick together because that's my whole piece about the residents and the faculty. Like the work is hard, like, and we're all trying our best and we need to be on the same team and the same side of the table versus opposing sides. So I think just chatting and peer support and hopefully we'll get a government who recognizes we're working our butts off.
There's a lot of questions online that we'll forward on if you get a chance.
Absolutely.
And, we are so lucky. One of the questions was around having concrete things to work towards. We're so lucky to have Mel. And so I know she's very open because whenever I've had situations, she's very open to having discussions, although I don't want to completely volunteer your time. But I think having this position, the Chief Wellbeing Officer, and the whole thing that you said, just the last piece, which is having some tolerance and kindness towards each other just goes such a long way. And so thank you. Really important. And yes, to Adrian's point, we will have you back hopefully in the near future to hear about the work that you're doing at the Royal College and locally. So
Yeah,
thank
I'd
you.
love to. And I do have lots of like very tangible things that we can do to impact now. Just so everybody knows, I'm going to be running around this place measuring a lot of things because I feel like if we don't measure it, we can't change it. So like measuring groups and understanding who's struggling and trying to, give that information back to leadership. So like there are some things that we can touch. So like I've got lots of ideas.
Perfect. So with that, have a wonderful day and happy Easter, everybody.